Well, welcome back to the VMed 22 main stage. Again, I'm Brennan Spiegel, and I'm really happy to present the next speakers for this session, which is titled The Virtualist, Latest Evidence from Clinical Practice. And we kind of came up with this term, the virtualist, many years ago now to describe the clinician who administers virtual reality in actual clinical practice. And our first speaker, Dr. Omer Liron, who is the co-director with me of our virtual medicine program at Cedars-Sinai and co-director of this program as well, is truly a virtualist. He uses virtual reality in clinical practice. He's a psychiatrist, but he's also, quite rare, both a physician and a full stack programmer and developer. Does his own virtual reality programming. He creates our programs here at Cedars-Sinai, and today he's going to talk about what's involved in doing that. His talk is entitled MXR in Clinical Practice, How We Design and Develop and Test and Deploy Virtual Therapeutics at Cedars-Sinai. So I can't wait to hear what he has to say. And I think you'll find that his insights are extremely valuable for those of you that are thinking about developing similar types of programs for your various clinical practices. So Omer, thank you for being with us today, and take it away.
Hi everyone, and thank you for joining VMed 22, and thank you Brennan for that introduction. My name is Omer Liron, and I'm a psychiatrist and co-director here at Virtual Medicine. Today, I want to share with you how we design, develop, test, and deploy virtual therapeutics at Cedars-Sinai. My hope is to provide everyone with a blueprint so that you can do the same in your organization, so that together we can grow the MXR's pie and reach more patients. I personally am a very skeptical person when it comes to grand scientific claims, but every day I see firsthand the power of VR to help our patients technomagically. This is an incredibly exciting space to work in, and I want to thank you again for being a part of this exciting journey. Here's the main claim for this entire talk. You can make MXR applications if you follow a recipe and avoid the pitfalls. If you're new to app development, you may see this as a mountain too steep to climb. Some of you will look up at the mountain and say, nope. But guess what? If you really wanted to, you can even climb Mount Everest. If these people can do it, so can you. You just need to keep putting one foot in front of the other. In full disclosure, I have no interest in climbing Mount Everest, but I do have a passion for creating. The best joy in the world is to see someone's life improve even just a little from an app that I created. Here's the bird's eye view of the method, and I will go through each of the steps in more detail. Step 1 is getting an idea for an unmet need and designing the app using human-centered design approach. We'll talk more about that in a little bit. Step 2 is creating the app, and this will constitute the majority of this talk. Step 3 is testing the app with patients, collecting qualitative data, and going back to step 2 to further update and improve the app. Finally, step 4 is to deploy the app to the target population. So let's talk about step 1, design the app. Here, there are 3 major steps that need to be completed in this specified order. The first, of course, is an idea. For this presentation, I will talk about our idea for creating a VR app to help patients with irritable bowel syndrome, or IBS. We set up weekly meetings to brainstorm ideas until we had a pretty good handle of what we wanted to create. For our app IBS VR, the idea was to take tools that have been well established by decades of research to help IBS patients and to create an entire virtual clinic around the therapies that are known to work best. Within this clinic, there are 3 sections with multiple rooms in each. The first is the educational center, where patients can go to the exam room and assume the role of a doctor through a role reversal exercise to gain a deep understanding of the known pathophysiology of IBS and especially the importance of the brain-gut connection. Patients can also watch educational videos about numerous IBS-related topics in the Learning Lounge. In the Skills Center, patients can go to the Theater of the Mind module to learn tried and true cognitive behavioral therapy or CBT techniques to challenge and replace adverse automatic thoughts. We worked with an experienced CBT psychologist, Dr. Robert Chernoff, to create a CBT script that can be administered in VR. Also in the Skills Center, patients can orbit the Earth to get a new perspective and literally have a conversation with their higher selves. This sounds strange, but tomorrow I give a talk together with Brennan Spiegel to go over IBS VR in more detail, so be sure to check it out. Then there's the urgent care, where patients can find gut-directed hypnotherapy, learn breathing exercises, and play games meant to distract from acute pain. And finally, there's a trophy room, where people see their unlocked achievements and find other ways to gamify the experience. The next step is to storyboard the idea. It's amazing how many things we get wrong by just writing a script down on paper or imagining a scenario in our mind before seeing them on a storyboard. Only by creating a storyboard do many of the details get ironed out. This here is our actual storyboard for the exam room. It doesn't need to be fancy, and even stick figures would do. Now comes the budget. Building these apps can be much cheaper than you think, if you pay for most of it with sweat equity. Here's a rough cost breakdown of a generic VR app. In the following slides, I will break down how you can achieve such a low budget in more detail, but it all comes down to row 7. The programming is time-intensive, but free. Sure, time is money, but at least for me, it's somehow often easier to find more time than money, especially when all you have to take to investors is an idea. Now, many of you may be wondering how the budget for the programming is 0. The truth is, anyone can learn to program a VR app, including you. If you try to outsource coding, you will find that your project becomes either extremely expensive or buggy, or both. Worse, when you want those bugs fixed, you're going to have to be very patient, and the outsourced programmer may even demand more money. Most importantly, if you try to make frequent minor revisions based on user feedback, your budget will explode, and the project will be in limbo for a long time. So, is learning to code impossible? Only if you believe it is. I live by this underrated quote from Alice in Wonderland. So, what do you need to know in order to create your own VR app? Well, you need to grab a game engine, and here there are only 2 options that you should even consider. It's either Unreal Engine or Unity. They are both amazing and you can't go wrong with either. I personally use Unity, but only for historical reasons. If you decide to go with Unreal Engine, you will need to learn C++. And if you decide to go with Unity, you need to learn C#. You also need to be proficient with Photoshop, or you can use GIMP as a free alternative. I use Adobe Audition for sound editing, but Audacity is an excellent free alternative. For 3D models, you can learn how to use the free app Blender, but hiring someone to create amazing 3D art for you is relatively inexpensive. If you do need to hire someone, we use Fiverr.com, where you can outsource some of the work, such as 3D art or music, to talented people. And there are other similar sites around the web. For music, you can also grab great music very cheaply from websites like audiojungle.net. And by the way, I have in no way paid or endorsing any company or application. I'm just reporting how we build our apps. So, to give you an idea of what we made, here's a short trailer. For a more in-depth look at IBS VR, check out the website at this address.
Hi, and welcome to IBS VR. My name's Maya, and I'm a virtual therapist. You are not alone. Okay, this was fun. Bye for now.
This is a screenshot of running IPS VR inside of Unity. I'm not going to teach you how to use Unity, but I want to give you an idea of what it looks like so that you know what to expect and see that it's really not as complicated as it first seems. On the bottom is just a file explorer. And on the left, you see a list of objects that are found in the scene. When you select an object, like the object Maya, who is our virtual robotic therapist, is selected here, the scripts associated with that object appear on the right. C#, like C++, is an object-oriented programming language. And all that means is that every object has its own script. And then those scripts interact. So Maya the robot has her own code attached to her, which tells her how to behave. Also on the right, you see that transform component, which tells you where Maya is positioned. It also tells you the rotation and the scale. And that's really all I want to say about Unity, but if you want to learn more, and I really hope that you do, there are countless of amazing tutorials online. I suggest you start by searching for Unity tutorials on YouTube. You'll get an endless amount of information. Once you are familiar with the basics, you can search for more advanced topics as you need them. For more specific questions, you can use your favorite search engine. Just search for Unity, followed by your question, and watch as millions of results flood your screen. For example, see this cool effect? 3 minutes ago, I had no idea how to do that, but I had an idea of what I wanted to do. I Googled it, and I followed the directions. As I mentioned before, learning to program is going to be essential, and C# is a great first language to learn. And there are countless of books and online tutorials. I particularly like the Head First series of programming books, so I can recommend you start there. Here is what C# code looks like. This is part of the Maya script we were talking about earlier. Now, I'm not going to teach you programming in this talk, but I want to point out a couple of things. All programming languages have if-else statements and loops. You can see several if statements here, which just say if something is true, then perform some action. Otherwise, perform a different action. In many languages, putting an exclamation mark before an equal sign means not equal. So, for example, the topmost if statement says, if this variable is not null, meaning it's not empty, then perform this action. You can also see some loops, which are highlighted in green. They essentially just repeat whatever is inside the curly bracket until a certain condition is met. Mainly, you will use for and while loops, and you can see examples of both here. The beauty about code is that you need to understand just a handful of concepts. And by the way, if you are curious, this code adjusts Maya's head rotation so that she can look and track a target. So which programming language should you learn? Like I mentioned before, if you're going to program MXR apps, then you need to choose between Unreal Engine and Unity. If you choose Unreal Engine, learn C++, and if you chose Unity, learn C#. If you want to program AI, such as neural networks, you should learn Python instead. And finally, if you want to program web apps, then I recommend that you either learn Node.js or PHP. And here's a bonus life pro tip. If you know one programming language, you can learn any other overnight. That's because all use similar logic. They have if and else statements, have very similar loops, just written out a bit differently. And because of search engines, you can just ask, for example, how do I write a for loop in Python? And you get the answer immediately. So let's talk about audio. Audio is especially important in VR because it can enhance or break immersion. For IPS VR, we're lucky enough to be able to use a professional recording studio for the voiceover work. But for other projects, I recorded at home with an inexpensive microphone with pretty good results. You just need to make sure to minimize reverb and background noise. And again, you'll find countless of tutorials online for how to do this. Here you can see the very talented Kate Makarov, who is a medical student, but also the voice of Maya. And by the way, I want to send a big thank you to Jeremy Roberts, who provided us with time and the recording studio. And Jeremy also provided us with much of the music for free. For those of you who play games, Jeremy composed the music for Skyrim, one of the most popular and best-selling games in the world. So we were extremely fortunate to work with him. Now, just for fun, here's a short behind-the-scenes look at one of our recording sessions.
At this point.
Our creative liberties.
Yes.
Ready.
Roll it.
Welcome to the conversation room. This is my favorite room in Spaceship Reflection. Here, you'll gain some perspective by moving in and out of your own mind and body. It's actually pretty simple. Here's how it works. You can see a caring and wise friend sitting on the other side of that frosted glass. That person knows a lot about what you're going through and is going to help you.
Nice. Very good. Very good.
Cool.
Next? Okay.
As I mentioned earlier, for editing the audio, I use Adobe Audition. You can easily fix a lot of common recording problems like mouth noises, clicks, and pops. You can also normalize the volume, copy and paste different pieces of the audio, and remove some background noise like low frequency hums. Like most other audio editors, it lets you add fades and other effects to the audio. So moving on to art. I am far from being a graphic artist. I can't draw to save my life, and 3D modeling anything complex would take me weeks or months. Therefore, I have to rely on hiring or outsourcing 3D artists, or finding 3D assets in an asset store. Luckily, both of these options are very easy and pretty cheap. There are many asset stores. In fact, Unity has its own. Once you buy the asset from Unity Store, you just need to click download and import to get it straight into your project. The assets are rated from 1 to 5 stars based on user reviews. As an example, I needed a duck for one of our projects, so I purchased the one that says Duck Animated for $15. It comes not just with a 3D model, but also several animations such as the gliding on water that I needed. I also wanted a duck link, but instead of purchasing one, I cloned the duck, made it smaller, and then edited the texture in Photoshop to make it yellow. And the results look like this. From here, it's just a bit of code to get the duck link to follow the duck at a certain distance. If for some reason you need very unique 3D models that you can't find in an asset store, you can outsource that through Fiverr or another similar platform for pretty cheap. Some of the people on these platforms do amazing work. Here's another app we made called VR Solace. We developed VR Solace especially for distraction from pain, but it has since evolved to include multiple modes, including guided meditation and breathing exercises. Initially, it was created for an NCA-funded study, but it proved to be generalizable, and so we're using it for other purposes as well. This is actually an important point. When you can, instead of redeveloping apps from scratch, generalize or modify the ones you already have for new uses. VR Solace is a great example of this, but we also plan on borrowing heavily from IBS VR so that it can be used for other purposes as well. VR Solace is about 90% art and 10% code, which is roughly the inverse of IBS VR. Most of the art was purchased from the Unity Asset Store, and here's a trailer for what that looks like. And that brings us to step 3. You develop the app, but does it actually help patients? Our research approach uses a methodology developed and published by a group of international experts. The method borrows ideas from medication trials. When a new medication is being investigated, it is tested in order from phase 1 to phase 3 trials. Similarly, when a new VR software is investigated, it should go from VR1 to VR2 to VR3. In VR1 trials, we test the app on users from the target population. We then gather qualitative data through open-ended questions, and we record the answers and get them transcribed. We especially love getting negative but actionable feedback because we can then iterate on the software to make it better, which is the whole point of the VR1 study. VR1 trials should be implemented while the app is still in early development so that it can steer you in the right direction. Until you test your app specifically on your target population, you don't actually know how they will respond to it. This is the approach to using a human-centered design for creating better apps, which is always important, but even more so for medical apps. So to summarize, the idea here is to design the app, collect qualitative data from the target population, analyze the data, and then incorporate the feedback into the design. Then do it again and again until you reach saturation and stop getting useful, actionable feedback. If you're interested to learn more about how VR1 studies work, we recently published our VR1 trial for IBS VR in the American Journal of Gastroenterology. You can check it out. VR2 trials test feasibility, acceptability, tolerability, and initial clinical efficacy. They are a precursor to the larger and costlier VR3 trials. Unlike for VR1 trials, VR2 trials test what happens when using the VR intervention not just on the target population, but also in the intended clinical setting. Before committing large resources to a VR3 trial, VR2 trials give researchers a chance to iron out logistical barriers. They also collect data on acceptability. For example, what are the reasons that some patients in the intended clinical setting refuse to participate? To test clinical efficacy, you want to design and power your study appropriately to detect the minimally clinically important difference for the patient outcome that you are measuring. In some people, certain VR applications can cause what is known as cybersickness or other adverse effects, and this is what we mean by testing the tolerability. Cybersickness is a similar feeling to motion sickness, and it causes terrible nausea that can last for many hours. To avoid cybersickness in your apps, keep frame rates consistently high. Frame rate drops may not even be consciously perceptible, but can cause people to feel very sick. Luckily, there are many tools to help you test your app's frame rate on the target hardware. Speaking of target hardware, we haven't discussed why we choose different headsets for different purposes, but I will leave that for a future talk. Most important for minimizing cybersickness is to avoid any camera accelerations. Cybersickness can occur when the vestibular system does not match the visual system. So, for example, if the camera is at rest and you want to move the user somewhere else in the scene, one way is to just move the camera gradually from initial position to target position. However, that means acceleration, going from 0 miles per hour to say 5 miles per hour and back to 0. I really recommend avoiding doing this. Either design your app so that the change in velocity is unnecessary, or if you must move the user, first fade the scene to black, then teleport the camera, and then bring the scene back. To collect quantitative data, we use validated questionnaires embedded into the VR experience itself. The subject answer questions using either hand controllers or their gaze, and the data is logged and transmitted to a secure server, which can then automatically analyze the data. We sometimes use biofeedback by collecting data from biosensors that can be embedded into the VR headset. For example, the HP Omnicept has embedded sensors to read in real time heart rate variability, pupil diameter, and eye movement. We get the data in real time and are able to show the patient how their physiology changes with their mental state. This reinforces the mind-body connection and we find that it has been a very powerful tool. Finally, this brings us to VR3 trials, which are the large randomized control studies that we all know and love. This should be methodologically rigorous in evaluating the clinical outcomes and safety. Now, in drug trials, the control arm usually uses placebo so that subjects don't know which of the pills are real. But then, what can be placebo in VR? For placebo, we use sham VR as a control in our ongoing VR3 clinical trials. Sham VR is like VR, but instead of an immersive experience, when you put on the headset, you see a 2D screen in front of you, like a movie theater screen. This way, the subjects still use the same hardware and still get the novelty of the new experience, but without the immersive qualities of true VR. Here's a list of our ongoing VR3 trials. To check eligibility, patients can go to our website and answer a few questions. Remember when I mentioned learning web development earlier? Here is one example where it comes in handy. Finally, after the app is fully baked, it's time to deploy it into our hospital and beyond. There are many competing approaches, and unfortunately, I don't have time to get into them in detail, but here are some general techniques that we currently use. First, if you're a clinician, then just go ahead and use VR. When I'm running in the hospital and I meet a patient who may benefit from VR, I just administer it. If you have students or volunteers who can help, even better. Another common approach is to create a research protocol to deploy VR. The benefit is that at the end, you get a publication out of it. The downside is that after the research is done, the VR stops. For a more permanent solution, you can protocolize it into a QI project. With the rise of virtual and augmented reality, we have been given completely new tools for helping our patients. This is an affordable technology that has been repeatedly shown to drastically improve patient outcomes. And so, I believe that it is time to roll it out not just as a research tool, but into clinical QI initiatives. So I hope that by now at least some of you are convinced that you can bring your MXR ideas to life, and that you go out and help us in forging the future. If you have any questions, feel free to email me at the email address here. And thank you again, and enjoy the rest of VMed 22.
Well, thank you, Omer, for sharing those insights, and I hope that was useful to those of you in the audience who are developing MXR therapeutics in your own practice or in your own labs. Well, next up is another virtualist. This is Dr. Melissa Wong. Melissa is an OB/GYN physician with a specialty in maternal fetal medicine here at Cedars-Sinai. And she has a longstanding interest in technology broadly. She does very interesting research with artificial intelligence, for example, but she's also been interested in virtual reality. And recently, she published a large randomized controlled trial using VR for women going through labor and delivery. And she'll talk about that today, and more broadly, talk about the evolving role of VR in OB/GYN. Her talk is titled Virtual Birthing, an update on experiences using VR to ease labor pain. And with that, I'll hand it over to Melissa. Thanks for being with us today, Dr. Wong.
Everyone for virtually hopping over to my talk, which really represents a sequel to the talk I gave at VMed in 2019, representing our experiences using virtual reality to ease labor pain. So I'll divide this talk really into three parts. First, we'll recap a bit why use VR for pregnant people in labor. Next, we'll move on to our and others' experiences using VR in labor. And then finally conclude with applications of VR in obstetrics, which have indeed evolved in these last 3 years. Before we get too into it, though, I will reiterate my most important disclosure. I don't have any financial ones, but that despite 3 years having passed and now having baby number 2, a pandemic baby in the house, I have continued steadfast in my position of not doing this whole labor pregnancy thing, and being very grateful to have a wife who's willing to do that for me. And I continue to feel very affirmed in this decision because our latest research from the 1970s continues to affirm that, labor hurts. And this is one of, again, the earlier published studies, but still one of my favorites to cite because it puts labor on the scale of a hurting akin to about as much as having your digit amputated or finger taken off. And it hurts truly in a myriad number of ways. So as we look to the left of our image here, and we can certainly see the easier part to understand are those kind of afferent neuroconnections. We break these down into T10 to L1 coming from the uterus, or S2 to S4 coming from the perineum, that sort of ring of fire type pain. But where labor does differ are these sort of cortical responses. So how women process that pain is very different. Again, it's coping with this pain to really get to this eventual goal of meeting their baby. Very different from losing your thumb, let's say. And so perhaps not surprisingly then, this cortical component, or how women process the pain, is extremely powerful. We know that one of the biggest predictors of whether a woman is going to get an epidural is her anticipation or personal coping score before she ever has a contraction. And while women know that labor hurts and know that there are options for dealing with that pain, they're also interested in alternatives to epidurals. So now I am absolutely personally epidural agnostic, but these 376,000 folks searching and replying on babycenter.com are not. And ultimately, according to our data out of Australia, upwards of 3 in 4 women will use some version of complementary and alternative medicine during their pregnancy, be it aromatherapy, biofeedback, acupuncture, hypnobirthing, or the like. And so at the end of the day, while our data tells us also that 73.1% nationwide will get an epidural, at some point there is this strong desire in this population to do something else. Something perhaps in the meantime until they get there. And so our question is, will that thing, if you will, be VR? Well, we already know that some of the most compelling VR data has happened in the realm of therapeutic VR in healthcare, whether in anxiety, mood disorders, neurorehab, or acute and chronic pain. We have, in fact, now so many studies that we have meta-analyses of all of these studies, all showing really robust effect sizes. But surely, we say to ourselves, labor is different. But perhaps it is different in particular ways that actually make it an ideal target, since we know women's perceptions are so controlled by their minds. And when we consider that VR for pain is postulated to work via a combination of distraction, acceleration of interval time, and actual literal obliteration of pain signals, here an example from a study where people during burn dressing changes were put in a snowy VR environment and their fMRI data showed these areas of nociception just not being triggered. So there is physiologic basis for its potential utility in labor. So then, given that potential capability, what do we know about its use in labor? Well, back in the old 20-teens, not much. There was, in fact, only the one crossover study of its use, so let's review that briefly. So this is the VRAIL study. The aim of this study was to investigate using VR to alleviate labor pain, and they hypothesized that it would work on these 3 aspects of pain: sensory, cognitive, and affective. They included women in their first pregnancy and early labor beyond 32 weeks and excluded any currently receiving pharmacologic analgesia, higher-risk pregnancies, or any VR-specific contraindications. They utilized a crossover design, which is important. So everybody was recruited and then randomized, so half the women ended up getting VR, and for 10 minutes, count it 10 minutes, they then surveyed those women and then took away the intervention for 10 minutes and then likewise surveyed them. The other half of the women started off the opposite, so they got no intervention, they then were surveyed them and then VR'd them and then surveyed them again. So this design allowed each woman to ultimately serve as sort of her own control in a way. And this is what they experienced for those 10 minutes: an ocean rift scuba diving simulation, and then this sort of like smooth jazz brain focusing stuff from brain.fm. They then submerged this very pregnant person with the manatees for 10 minutes and were like, have at it. Anyway, they all then took pre and then 2 post surveys. And these are the results. They enrolled 28 women. One had to withdraw, actually, because she wanted to use hydrotherapy, which always makes me smile. There were no adverse events suggesting it was a good idea. They didn't let the lady who wanted to birth in the tub keep the VR headset. And not surprisingly, of course, the majority eventually did get an epidural. So here were their main results. So again, comparing the same woman sort of assessing herself in her VR state, the left darker bar in each set, versus her non-VR state, the white bar in each set. Starting with her primary outcome, her worst pain intensity was 1.5 points lower in the VR arm. In addition, the time spent thinking about the pain was a little bit less, cognitive aspect, and the unpleasantness of the pain was less, the affective aspect. Reassuringly, there was no difference in nausea, so despite submerging a woman underwater, they didn't make them more nauseous, which is great. And interestingly, no difference in anxiety related to the pain, which may have reflected that it was just a shorter intervention overall. With only 10 minutes, you're really only talking 3 contractions thereabouts, so not much time to know whether you've affected that anticipatory component. So in summary, it seemed like it may have had an effect, but there were a few issues with the study. They didn't actually meet their recruitment goal, they needed 30. And it was also a crossover design, which is really tricky when the interventions themselves are so short. So with 10 minutes, how much time did you really have in between? How do you know they weren't still sort of getting that high from VR in the groups who got that first? And of course, the limitations of just sort of only a 10-minute VR experience. All in all, though, it was really interesting, certainly interesting enough to compel us to think, yeah, I think we can do a little better. So the objective of our study was to evaluate whether VR was effective in reducing pain in laboring women, and we hypothesized that it would be. So our design was a randomized controlled trial. It was unblinded to the patient, study staff, and assessor. Well, other than the patients, they were a little blind with that VR headset. Sorry, it's a VR joke. Pragmatic design, meaning that whatever they were concurrently doing didn't need to be altered. So if they were lucky enough to be getting aromatherapy or massage at the time, we didn't take that away. Half of the women were randomized to virtual reality, half would be randomized to no additional intervention, and it was approved by all the appropriate bodies. We included nulliparous term women in the first stage of labor whose pain score was 4 to 7 and were contracting at least every 5 minutes. We excluded any persons who had received any pharmacologic pain relief, whether oral, IV, or regional anesthesia like an epidural, as well as those who were at risk for seizures and those for whom the use of VR would be medically contraindicated. The overall procedures of the study are described here. We began by recruiting and obtaining consent. All patients completed a series of pre-intervention questionnaires, including a childbirth self-efficacy inventory and promise scale. Patients were then randomized as described, half again to 30 minutes of VR and half to no intervention. Participation could be discontinued at any time or if additional pain management, such as an epidural, was requested. Throughout the intervention, maternal vitals and the fetal heart rate and tachometer contraction monitor characteristics were being documented. It is worth noting that study staff remained in the room for all subjects so that the control or no intervention arm did have the exposure of me sitting quietly, awkwardly in the room while they yelled in pain. Following the intervention, pain scores and vitals were reassessed for both, and then additionally, those in the VR arm actually took a post-VR qualitative survey and underwent a guided interview. So the particular VR intervention we used was a visualization called Labor Bliss. It was designed by Applied VR, a company here, in conjunction with a doula. And what made this intervention particularly unique was not only the relaxing visualization, but also what was coming through the headphones. So the patient actually heard messages pertinent to a person in labor. So for example, you can see here, contractions are waves of energy bringing your baby closer to you. So not quite how I might describe contractions, which is perhaps why they did not ask an MFM and went with a doula for this auditory script. So our primary outcome here was a difference from pre to post intervention pain scores between arms, and our secondary outcomes included surrogates for pain. As well, we collected maternal and fetal vitals, OB outcomes, and qualitative assessments from the subjects who'd received VR. We powered our study for our primary outcome using a measure called a minimum clinically important distance for pain. So this scale has been established in the literature and reflects that starting at a baseline higher visual analog scale pain level means needing a bigger clinical change in pain score for it to be relevant. So for pain score levels 4 to 7, our inclusion criteria, the minimum clinically important distance, was 1.3, and we calculated we'd need 40 subjects to achieve our power. So now for our results. So over the course of 1 year, 40 subjects were recruited, all received the intervention as allocated, and none withdrew consent or were lost to follow-up. Baseline demographics between the two groups were similar with the exception of race, with fewer white and more Latinx subjects in the VR arm. BMI was also slightly higher in the VR arm, though other clinical characteristics were similar. Half the subjects were being induced, and about mean dilatation prior to the intervention was 2 to 3 centimeters out of 10. The PROMIS score, or self-assessment of global health, was slightly lower in the VR arm, though the groups did not differ with regard to previous VR use, interest in VR or complementary alternative methods for pain management, or plans for pain management overall. So as a reminder, our primary outcome was again that difference in differences, or in other words, the delta between pre and post intervention pain scores, here shown for one patient. So then looking at each individual patient in our control arm then, what is apparent is that doing nothing to a woman in labor, over 30 minutes, her pain scores tended to stay the same or get worse, and in fact, none improved. In contrast, in the VR arm, while some did experience the same or worse pain, many also experienced reductions in their pain scores, including this subject, who I kid you not, went from nails digging into bed rails to asleep, and I had to wake her up, and she says, "Oh, I guess my pain score was 0?" So putting these numbers in summative terms, the control arm overall saw an increase in their pain by 0.58, the VR arm a reduction in their pain by 0.52, and the difference in these two differences was statistically significant. Other pain-related outcomes between the groups were similar, including pain scores at 2 and 4 hours after the intervention, and when and whether they received an epidural. Of note, though, the maternal heart rate was lower in the VR group, though blood pressure did not differ. Finally, obstetric outcomes did not differ by group. And in summary, the objective of our study was to evaluate whether VR was effective in reducing pain in laboring women, and we concluded, in fact, that it was. So our study is consistent with the one other published study of VR in laboring women and is strengthened by its randomized controlled trial design. It's also pretty fun that it's the largest study to date, using the longest VR intervention of any labor study to date, and the only to use a labor-specific intervention. In addition, our secondary finding of a reduction in heart rate was biologically consistent with a reduction in pain. However, of course, it's limited by the unblinded nature and by the short duration. In addition, in choosing no intervention as our control arm, it's unclear whether it was the VR or just being distracted that really produced the effect. And finally, I'll add in, actually just as a little epilogue, this peek at some of the data that we've analyzed but not yet previously shared, a look at the real qualitative data on what patients told us during the guided interviews regarding their experiences using VR in labor. So patients completed these childbirth self-efficacy interviews prior to and after completing VR, and the blue is their baseline self-efficacy, and each of the orange colors is a quantitative assessment of the degree to which they felt VR would help them with each of these self-efficacy type tasks. So you can see they anticipated in a lot of these metrics it would be really helpful. For example, extremely helpful in relaxing their body and using breathing and staying in control, in not thinking about the pain, which again, consistent with where VR's benefits are. And there was less difference in being able to focus on the baby, which kind of makes sense per se, or self-motivation, but again, meaningful changes in a lot of metrics. And then really getting to the guided interview, this is a mind map of the themes that came out. So what we heard time and time again was a decrease in the anticipation of ongoing pain or that next contraction. Labor is truly unique in that once you're in a rhythm, you know it's not letting up until you meet your baby. So it's not just getting through one contraction, it's also knowing that one is following like clockwork 3.5 minutes later. And VR seemed to really help with that. They did seek really specific pregnancy-focused material and wanted more and more material, and found that having that made it more relevant to their experience. And so with these 1.5 projects done, our next steps are to analyze the data gathered in this trial for VR's effect on the fetal heart rate. We hope to design a future trial for continued access during labor, to further optimize labor-specific visualization and incorporate device-based biofeedback, either through the actual contraction monitor or breathing-based biofeedback, as well as to explore other potential utilities during pregnancy. And so with that in mind, before I go, just a tour of what are other potential utilities in pregnancy, what else is happening out there. So this is work that really spans multiple domains, from patient education, medical education, advanced imaging, and then I'll swing us back to therapeutic VR, which is an example in each. So first, patient education. So some of the earliest kind of quote-unquote patient education where they used ultrasound rendering to be able to convert images obtained for a fetal anomaly, let's say, and convert that into a 3D rendering of your baby, which you could then, spin around. felt like these were kind of honestly more closer to VR as marketing more than they really were healthcare. Unlike, though, for example, what I saw then that they were doing at Stanford these last couple of years, which I thought was genuinely an approach where VR improved patient education. So Stanford actually has a fairly robust fetal therapy program, and they developed a VR simulation to better explain to patients what happens in a solemnization procedure for twin-twin transfusion syndrome. So twin-twin transfusion syndrome is a condition where there is sort of a disparate sharing of the blood flow in a shared placenta so that one twin gets too much and one gets too little. And in a solemnization procedure, a fetoscope is inserted through the uterus, through the sac, and a laser is introduced to photocoagulate those problematic anastomoses. So that in this program, as the patient, you can actually be handed a headset and a controller and then hop into that uterus and be surrounded by and see the physiologic changes yourself, as well as perform the laser photocoagulation and see those changes reverse. So it's quite a different experience than just sort of reading handouts or watching a video. And they've actually now published data that, not surprisingly, patients understand the procedure much better. In medical education, so this field is particularly more developed outside of OB, where they've got really robust sim. And to find examples in OB sim, we kind of have to go a bit further back across the pond, all the way to Australia, where they're training midwives in pelvic anatomy using virtual reality. I think most of us who deliver babies, whether OBs or midwives, think at least high-fidelity sims would be ideal, but that said, the ability to understand some of the cognitive aspects of delivering anatomy can certainly be improved by these systems. Moving on now to imaging. So when I think about what VR can do for imaging, it's almost like 3D plus. So for those who have seen 3D, it's kind of those things that people post on, I don't know, Facebook or Instagram. You can get at a mall. And it's a sort of a re-rendering of what you get in ultrasound, but just put into a 3D looking thing. And this field is really just starting, but it is also pretty amazing. So this is an example for those who can see of a normal first trimester 3D ultrasound. And this was a rendering in virtual reality, which then, when they were able to sort of more easily spin it around in the VR environment, allowed them to diagnose this anomaly, thrombocytopenia absent radius syndrome. Or here another example in a conjoined twin pregnancy, where accurate diagnosis is particularly critical since it will guide prenatal counseling as to whether or not the identified anomalies are lethal. So in this case, one team of experts was given the 2D, 3D imaging, and another team was given VR headsets and the images through that. And what they found is that those who were given the VR headsets were actually able to more correctly identify the fourth arm, an abdominal defect, abnormal ulnar deviation, and severe scoliosis, none of which had been seen by the teams looking at 2D or 3D images. In a subsequent paper, they found that they were able to dial up the identification of anomalies by an additional 10%. And then last, I'll swing us all the way back to where we began this talk, VR therapeutics, where there are a couple of trials that have been done. So first, an external cephalic version. So this is a procedure where the clinician basically uses their hands to manually manipulate a fetus from breech or bottom down to head down. And it's just about as comfortable as it sounds. But at Monash Medical Center, you can see that their patients are entirely oblivious to this. So this patient, for example, is wrapped currently in a world of Chinese lanterns through an immersive app called Skylights. So it's a pretty far cry from the discomfort women usually feel. And while they didn't officially find any difference in pain scores in this first trial, so it was in this pilot study, they were powered primarily for feasibility, and they found that it was feasible. So I anticipate they'll broaden it further now that they have this. Yet another hot off the presses thing in VR was its use for amniocentesis. So this time again back across the pond, this time in Tel Aviv. So this was a randomized controlled trial of 60 persons undergoing a mid-trimester amniocentesis, which for those not familiar is where you take a needle 6 inches long, and it's inserted through your abdomen into the uterus, through the amniotic sac, and a little bit of fetal urine is withdrawn. So they didn't actually describe what the particular content was for the video, but I imagine ASMR of a balloon popping was pretty quickly taken off the list. Their primary outcome was a visual analog scale change in pain score. And here on the right, you see a patient flow diagram. So I'll just highlight that I might disagree a bit with who they excluded from the analysis in this theoretically intent to treat, since removing the headset for nausea was excluded. But anyway, tomato, tomato. Anyway, in total, they counted 30 in the VR arm and 30 in standard of care, and lo and behold, success. So the mean VAS score was lower during the procedure for those who received VR. And so that's really it in terms of what's published on this topic in therapeutic VR. But I will say, anytime I talk about potential uses in OB, I just have to bring up this other previous application in the postpartum period because it's one of my favorite and centers around breastfeeding, or rather pumping. So this is Pinar. And Pinar at the time was a PhD computer scientist working at MIT in artificial intelligence. Quite impressive in her own right until she met her match in Ada. Ada, of course, is Pinar's daughter, and while she initially latched well, eventually sort of lost the hang of it, leaving Pinar in the oh-so-common quandary of pumping. And pumping, for those less familiar with it, sucks. So best case scenario is you're in your office or sometimes in a corner of a lactation room or in a bathroom and trying to make this magical thing happen. And so when the MIT hackathon had as its theme, make the best pump not suck, Pinar and her team got to work creating an immersive VR experience to make pumping suck at least a little less. So why VR for this? Well, because when it comes down to it, pumping is very much a mental thing, with milk supply volumetrically dependent on your frame of mind. So they thought, why have to endure an office or bathroom walls when you're pumping? Why not be in your nursery, with your dresser and your wallpaper, or that weird grid number thing all of us are standard issued once we have kids? It's fascinating work, and it won her group the prize at the MIT hackathon. But Pinar has, as one does, moved on to other things, so this is a bit of a footnote in her bio, but I think represents a tremendous opportunity for work in this field, which is why I always bring it up. So that about wraps us up. I hope you've come to understand why VR as an alternative pain management for pregnant patients might make sense. We're able to be introduced to what our own study in the field, as well as toured through what else is happening in the space of VR and pregnancy, because be it in patient ed, medical education, advanced imaging, or VR therapeutics, the field just continues to gestate. So I would like to thank tremendously all of the labor and delivery staff, nurses, residents, midwives, physicians, and most particularly all of the patients who were gracious enough to participate in the study, as well as special thanks to my mentors, Dr. Spiegel and Gregory, on this project, and look forward to your questions, virtual or emailed or tweeted or otherwise. Thank you.
Well, thank you, Melissa, for that talk. As entertaining as always. Always love hearing Dr. Wong speak here on the main stage at Virtual Medicine. Now, next up in our list of virtualist speakers today is Dr. Howard Gurr. Dr. Gurr is a psychologist who has been practicing for many years in Long Island in New York. And he's been focused on using virtual reality now in his clinical practice for the past 7 years, and routinely uses it to manage a wide variety of conditions. Now, there really still aren't very many people like Dr. Gurr who routinely use VR in clinical practice. So we invited him to the main stage today to talk about his experiences using virtual reality. And he'll be talking to us today about, his title is The VR Psychologist, How I Use Virtual Exposure Therapy in Clinical Practice. So thank you so much, Dr. Gurr, for being with us today at Virtual Medicine.
Hi, I'm Dr. Howard Gurr. I'm a clinical psychologist on Long Island, New York, and I have to say that I'm very humbled to be asked to present to you at VMed 2022 regarding my private practice. Many of you are pioneers in the field, and I'm in awe of your work in VR. I see myself just as an end user, a clinical psychologist who uses VR to enhance exposure therapy. And today I'm going to talk about my use of VR and also how I got here. Anyway, so let's start. This is where I am. I work in Long Island, or on Long Island. It's an island that's fairly large. There's about 3 to 4 million people who live on the island. I have to say, though, that there are, of the 2 major counties, not including Brooklyn and Queens, because they don't believe they live on Long Island. But the Nassau and Suffolk counties, there are probably at least 2,000 mental health workers, at least 2,000 psychologists, and I can count on my hands the number of psychologists who use virtual reality in their private practice. So widespread acceptance has not been reached, so to speak. My background is I graduated college a long time ago, and I opened my practice up in 1983. But in 72 to 77, there was a TV show about Bob Newhart, who was a psychologist in Chicago, I believe. And he went to work every day at about 10 o'clock in the morning and seemed to come home at 6 o'clock for dinner every night. And I thought that was a pretty good life to have. Of course, that's not really what happened. It turns out that you have to work late hours and long hours. And people have to go to work to be able to afford coming to therapy. So evenings became a major portion of my day, and I would leave the house early in the morning and come home 8, 9, 10 o'clock at night. So it wasn't what it was cracked up to be. I still love the job, but that's not what I was sold. The bill of goods I was sold. Anyway, so I'm a general psychologist. I have a degree in, I'm a dual PhD in clinical and school psychology. I worked as a school psychologist and a clinical psychologist at the same time. So I had the range of patients from, I would say to people that I had patients, children from 5 to 90. And over the years, I kind of honed down the practice to work with a lot of phobic patients. And it was difficult in the beginning using traditional techniques for a variety of reasons. Also, the fact that phobias are situations and problems that people tend to hide. So the data we have is that a good, I'll put myself over here, a good percentage of the population have significant phobias or anxiety disorders, but most of them choose not to seek treatment for fear and their own anxiety about treatment. Plus, people tend to have a tendency to find ways to avoid phobic circumstances until their life changes, and then they can't anymore, and then they have to do something about it. So in terms of phobias, this is the list of the diagnostic criteria for phobias. For the sake of time, I'm not going to read all my slides. I'll be talking, and you could be reading them. Let me just get myself even lower and smaller so I don't block any of this. And so essentially, the phobia basically interferes with one's life significantly and causes difficulties living a normal, typical existence. And so the anxiety is really disproportionate to what it should be, and it interferes with too many aspects of one's life. Now, we tend to jokingly call anxiety really as the what if syndrome. And again, I'm dating myself a little here because that's Barney Fife, and I'm blanking on his name. But anyway, this is from Mayberry RFD, Gomer Pyle, that's it. And these guys were always a little apprehensive, and I always loved that look on Don Knotts' face when he was panicked about something. It was like the epitome of panic and anxiety. And so the what if syndrome is really because essentially that's the core question people ask. What if? What if this happens? What if that happens? And so we have to address the what ifs. The other thing that happens is, and I call this head and shoulders, but it's that when people get stressed, they tighten up their shoulders and body. And I believe there's a loop somehow between the brain and the shoulders. I believe that when the brain feels stressed, the shoulders go up. And most people are unaware of the fact that their body posture is affecting their anxiety level. And so it's important to teach people to recognize their body and recognize what they're doing with it at the time when they're stressed. Obviously, breathing is another important piece, the diaphragmatic breathing, which we'll touch on a little later. Now, in terms of treating patients with phobias pre and post VR, before VR, I had to rely on, imaginal exposure. In other words, patients had to sit in the office and say, okay, I would tell them to imagine they're in a situation that's stressful to them. Imagine you're driving a car. Imagine you're in a plane. Imagine you're facing a dog that's scary to you. And of course, most people had difficulty holding on to those images because they were scary. Plus, lots of people don't have great imagination. And so that's one end of the spectrum. The other end of the spectrum was the in vivo exposure. And people had to, essentially, we had to go places and do things. And so if they had fear of driving, you had to be in the car with them towards the end of the therapy while you were working with them. Or, some people would actually go on planes and take flights. But it became cumbersome and time consuming, and I was always looking for ways to speed that up. Of course, in terms of dealing with phobics, compliance is an issue, and there's a high dropout rate because they get frustrated. With the advent of VR, I no longer need to rely on people using their imagination. The information's fed to them, and it becomes easy for them to be in that environment. And there is control, because even if they're exposed to a virtual environment, then they get kind of hijacked to a certain extent. They know that they can take the head-mounted display off and they're out of it. So they still have control. Virtual reality still has kind of novelty effects. And so because of that, it seems to be more engaging. And the big thing is faster results. I could get things done in 6 to 10 sessions that would take me months and months and months. And it just works better. So I don't know why people aren't using it more often, because it just makes more sense. Now, the physical symptoms of panic attack are really sympathetic nervous system, protecting the body and the brain. And so people describe things like chest pain because of the tightening in the chest. It's not really chest pain, it's muscle. Chills, flushes, excessive sweating, feeling dizzy, lightheaded, feeling numbness, tingling, heart palpitations, nausea, shortness of breath, and trembling. And essentially what's happening is the sympathetic nervous system is engaged instantaneously. And what it does is it produces adrenocorticosteroids, pumps out adrenaline. It says, you know what, I need to protect myself right now. So whatever I ate, I don't need to digest. I'll deal with that later. The pupils dilate because the brain doesn't know essentially whether you're going to be in a dark area or not. So it's not taking any chances, and it engages the pupils to dilate. The lightheadedness and the feeling of fainting is interesting to me, in view of the fact that what the brain does is it says, oh, I'm pumping a lot because I need to get the muscles, the peripheral muscles moving. But then it says, well, wait a second, hold it. What if I have an injury? I'm going to bleed out. So it starts slowing everything down and the blood pressure drops. And of course, that's where people feel like they're going to faint. Of course, that would be the worst thing in the world in a panic situation, to faint, because you'd be the most vulnerable. So patients don't faint, really. They think they're going to, but they don't. They also think they're having a heart attack, and they also think they're going crazy. Those are the options that they have because they're out of control. And so all this happens instantaneously. And of course, the system that shuts this down is the parasympathetic nervous system, but that's also pretty slow. And this process goes on for too long for most people. And the problem we have is that they panic about being panicked. And so that prolongs the whole process. Now, as I said, I'm one of the few people on Long Island who is using VR. And my practice is I get referrals from 3 different basic sources. Patient referrals, online marketing programs where people see me online. And what's also significant to me is other therapists will send me their patients. So people are in therapy, and in the process of the therapy, they say to the therapist, oh, I have to travel on a plane, and I haven't been on a plane in years. And the therapist says, well, I can't get you there fast enough. Go see Dr. Gurr. And what happens is I would see them, work with them individually, primarily on what their problem is in terms of the phobias, fix them, send them back. So a third of my practice really is referred by other clinicians. Now, I do have exclusions in my practice because, as I said, I'm a solo practitioner, and I don't have a connection to a larger facility. So I kind of limit the quality and issue of what kind of patients I take. Now, when it says borderline personality disorder, I will take them anyway, but in the beginning I wasn't going to. But just get an idea that these are the circumstances that would stop me from taking a patient. Now, in my practice, I originally thought I was going to be working with public speaking anxiety, and it's not exactly high on my list. So fear of driving seems to be number 1, and fear of flying is number 2. Fear of heights is big. Closed spaces and MRIs in animals, they're pretty close. Fear of open spaces, I've had people who have difficulty with malls, open areas, children with a fear of injections, some social anxiety, some public speaking anxiety, primarily actually singers. I used to work with a bunch of singers, voice professionals, so I still get referrals sometimes from them. And then I used virtual reality for generalized anxiety, or just to give patients the idea of what it feels like to be relaxed and how to use virtual reality to get them to reduce their anxiety on their own. Now, as I said earlier, clinicians aren't picking up VR in their practice for a variety of reasons. One is that they're not really comfortable with technology. Two, they don't feel like they were trained in this use of VR for exposure therapy, so they're not going to jump on something that they feel that they weren't trained for. And the other important thing is that clinicians believe sometimes that the VR gets in the way of the relationship between the therapist and the patient. And that's not really true. It's supplemental. And I think even in my particular practice, I do talk to patients while they're in VR. And so, there is that relationship, and we are talking and going over stuff. So it's not like the VR completely blocks us out. As you all know, VR is evidence-based. And I also think it's important to know that regardless of the fact that there may be a package or a platform that somebody uses, it really requires some creativity to think outside the box. So for example, all the packages have generalized virtual environments. It would be a generalized highway or a generalized area or street. And I think that that's okay, but I get to the point where I have to go beyond that. And so what I use are Google Maps to find a specific street, or 360 YouTube videos. And I use them to get the person to be exposed to the virtual environment closest to where they have problems, or actually there. So for example, on Long Island, we have a road called the Long Island Expressway, which is pretty horrible. And most people who have difficulty with highways will not go on the LIE. And so somebody out there, many people out there, have recorded 360 videos of the LIE from one end to the other. And I could use that as the vehicle in the head-mounted display to get people to actually be feeling like they're in a car on the LIE. And that improves the immersion and speeds up the process. Now, in terms of my practice, the telephone is my intake. And so when people call, I try to find out if in fact they are appropriate for VR. And I also give them a lot of information about VR and what we're going to do, and the physiology and the psychology, so that they're already prepped. Because most people would want to actually, because they've sought me out, want to get into VR very quickly. Now, I know there are clinicians who say, well, by the third or fourth session, that's when we start with VR. I start right away. I'll put them in a VR environment first session because I want them to know what they're dealing with, and I want them to get that experience. And that's what they were seeking. But I wouldn't necessarily put them in a threatening environment. The first session might be just a virtually relaxing environment to teach them to recognize kind of how the VR actually kind of hijacks their brain a little, and also helps them to relax. Now, in terms of my therapy, the goals really are to normalize. So in other words, I want patients to know that they're not that strange, that panic and anxiety and phobias are pretty common. I want them to get to understand that they're not out of the ordinary in many respects, and that most people, one time or another, are going to have some kind of phobic or panic reaction. I teach them about the sources of their anxiety, and we talk about genetics, medications, history, traumas, anything that might contribute to their phobia. Increased body awareness is important because I want them to recognize that the mind-body connection is very important. And it's not that we're dealing with just the brain or just dealing with the body. that there is a correlation between the two of them, and they feed off one another. And the feedback systems that the body has are very sophisticated, and I want them to realize this, so they need to be educated. The key for most people is that sense of loss of control, and so it's important for me to give them that control back. And so they have some sense of having the ability to manage their life. And also I teach new skills. I want to teach them not to use avoidance, because that's not helpful, but teaching skills like humor and refocusing and some distraction while they're in the sense of being in the virtual environment or the in vivo environment. Basically, you know, what we know is that you can't be panicked and laughing at the same time. So we try to teach them that to use laughter as that tool. Now, I use GSR and HRV for feedback, but since the pandemic, most of my work has been done remotely, and so I'm kind of left with subjective units of distress, which is a subjective scale. Although more and more people are beginning to pick up HRV on wearables, which is very helpful, so that we could use that HRV data. So I have people who are like driving with an HRV device on their finger, and their phone is reading out their HRV numbers as they're driving. So they can now take a look at how they're doing and how their HRV is, and it gives them constant feedback. So I'm going to give you a couple of cases in reference to my work. So the first case that I'm going to talk about is a guy who, this is a picture of Amalfi. And what happened was, or it was June, and the patient called me and said he scheduled a trip for Amalfi, and then looked at the itinerary and realized everything was on cliffs. And this particular guy had a problem for most of his life. He was in his mid 50s. And at the age of 10, he and his friend were climbing a tree, and the friend must have touched an electrical line, and he was electrocuted. And since that time, he would not go near heights at all. And he never sought treatment for it because he didn't need to. But now all of a sudden he had to. And so he told me the trip was in August. So I had about 6 weeks to work with him. And we did it. Now I'm going to talk while we do this, but you could read the slide. I just in deference to time management, I'm not going to read all of this stuff. But let me just give you the summary as we're going through this. So I used a virtual glass elevator for him because it would give me the height issue, and also pretty much most people would have difficulty with the elevator to begin with. And so that's how I started. And he was pretty intensely anxious. In fact, he almost fell over the first time. And in a couple of sessions we worked on that, his subjective unit of distress scale went down. And when I work with patients, the end of the session, I always leave them with a virtually comfortable environment, like a relaxing environment, so that they don't leave stressed. For him, because I live on Long Island and it's flat, there aren't too many places where he has height, but I found a mall where he could go, and he could stand at the rail and look over the railing to the first floor, which took him a couple of weeks to get comfortable with. And after 6 sessions, he basically took the trip and he felt better. Not that he loved heights, but he enjoyed the trip. And so to him, it was a success. I had this woman, again, pre-COVID, who had a fear of flying. Now, this patient lived in Denver, and she wanted to come to me. I tried to talk her out of it because it was so far, but she refused to take any other recommendations. So she drove from Denver to Long Island and was here for 4 days. She had some significant history. She did fly early on, and then all of a sudden she couldn't. And I guess starting around 13, she started to have panic attacks that became significant to her in terms of impairing her life. And she didn't really have to fly for years. And then all of a sudden her job changed, and now she had like a lot of flights to take. And so I only had 2 days to work with her. And so she came in, and the first day Again, I went through the education. We talked about the sympathetic nervous system, back brain versus front brain, core concepts, all the stuff that she needed to learn to be comfortable with the VR information. And then I used a couple of flights. The thing about VR is you could actually go up and down 5, 6 times. You can't do that in real life. And so for her, I took a whole bunch of flights, and essentially in 2 days, we basically got her where she needed to go. I taught her the cough technique, and that's simply when the first symptom comes up, whatever it is, the first physical symptom, if you cough real hard, sometimes you're able to shut off the adrenaline pump. And it did work for her. She did much better eventually, and she recognized that the engine sounds were a problem for her. And this is what essentially a summary. She did fly about 50 times and basically felt like she was cured. And she even started drinking coffee, which was something we tried to avoid. Now, post-COVID-19, as I said, I've seen patients only virtually. And so we've been using here Amelia, TheraVR I've played with in terms of virtual environment where two people, you become an avatar and you're in the same environment. And then the other one that I used was Virgil's. And Virgil's, again, works on any platform, but I would have the two guys who own Virgil's, Christian and Becco, create virtual environments that I needed, whether it be like a room with a 360 video or a room where there might be smaller rooms for claustrophobia, that they were willing to do that for me to test out their virtual environment. And again, it's another environment where you're as an avatar in the same environment as the patient, as opposed to being a distant situation like in Amelia. So let me give you an example of what I did with them. I had a patient who I saw before the pandemic, and he wanted to come back for a boost because he was afraid of crossing bridges. And what Becco did for me was to create a room where there was a complete wall that was just a video of somebody that somebody created going over the George Washington Bridge. And we sat there, and the patient actually became anxious, and eventually we extinguished the anxiety in that environment. I can't say that we were very successful ultimately because he didn't come back and I needed more time with him. But using that environment was very interesting. So I'm running out of time here. My take really is that VR works. It should be used much more than it is. For those who produce VR environments and platforms, dashboards have to be simple and interfaces have to be easy because clinicians are very limited technologically. And I would say market to new clinicians who are willing to kind of like take on technology. Now, here's my dream. Again, I'm dating myself. The holodeck on Star Trek 1, where the crew would go to R&R, and the room was kind of like a blank, but you could program it to have anything you wanted. And so if you were going to go to an 1800s saloon, you could create it, and the avatars were interactive. This would be terrific for working with patients because you can create the environment and have active avatars who are going to interact with them. So that's my dream. I'm out of time, and so I appreciate it, and I hope I was helpful.
Well, thank you, Dr. Gurr, for sharing with us your expertise and experience using virtual reality in clinical practice. And thank you to all of our speakers in this last session on the main stage for day 1 of Virtual Medicine 22. It's been an amazing day of presentations. And for those presentations you might have missed, whether on the main stage or over in the XR Theater, they will all remain available on demand after the conference is over, and available for 12 months for everyone here who has registered for VMed 22. So then we're done for the day, but we're not quite done because we now have our AltSpace VR Mixer. This is an opportunity for everyone to meet one another in the virtual world of AltSpace. We've made a special little space for you online. And by now, you all should have received a communication from our staff at VMed, providing you with information about how to access the AltSpace VR mixer. Either you already have a AltSpace account, or if not, we gave you instructions for how to create one and a link for how to get into this private event. As a reminder, you don't need to use a virtual reality headset. You can, if you like, to have the full VR experience, but you can also do it on a regular old 2D screen. This will be a chance for us all to meet one another. For those of you that are in Europe, and I know there are many of you, thank you so much. If you're still up and listening to this and want to join us, we very much welcome you joining us, even if you're kind of tired. But thank you so much again for everyone who has registered. It's amazing to see how many people we have this year joining us. This is a record year for us. Of all the years we've done this event, this is the highest number of registrants we've had. So thank you everyone who's been listening in and participating in the conference to date. And we will see, hopefully, many of you soon in AltSpace. And for the rest of you, hope to see you soon, tomorrow, where we will continue with another day of virtual medicine. Take care and have a good night.